At this juncture, you may want to take a look at that flow chart that I began our discussion with. Do not lose sight of what we are trying to accomplish. Our objective for that flowchart was to take a normal cell and then, upon exposure, various elements such as chemicals that I walked you through include arsenics such as chromium, such as nitrosamines, so on and so forth. The patient may develop a cancer, or if the patient is being exposed to certain viruses here, may develop cancer. Let's talk about HPV now. Our topic is the DNA virus that the patient has been exposed to and he or she develops cancer. How HPV is a big deal. Listen, with HPV, you should be thinking about a sexual transmitted infection, right? STI. With HPV, could be male or female, put them both together. And with HPV, you should be thinking about the higher strains, not the lower. My topic is cancer, HPV 16, 18, 31, and 36. 33. And with HPV in a female, you begin with the following. There might be vulvar issues, so there might be squamous cell cancer of the vulva. You keep going. There might be issues within the vagina and in the cervix. Would you tell me the part of the cervix that is facing you? Meaning facing you as a clinician when you do a pelvic exam. That is the exocervix. What kind of cells is your exocervix? Squamous. There you are in the transformation zone. Are you there? Put yourself in the cervix and the transformation zone. That which is facing the external world, exocervix, is squamous. That which is facing the uterus, ectocervix, is the columnar. That is your transformation zone. Now you tell me quickly what it is within the vagina that allows for the cells to remain squamous, the decreased pH. What is the bacteria that remains within the vagina that provides that type of acidic environment? Lactobacillus. Keep all that in mind because with HPV, 65% of the time, if the patient cervical cancer, where is your patient most likely coming from? Developed or developing countries? Good. Developing countries. 85% of the time, if you are in the transformation zone, the virus has the choice of either becoming a adenocarcinoma or a squamous cell cancer. 85% of the time, what is it going to choose? Squamous. Not only that, with HPV, maybe you have a couple that practice oral sex and fellowship, so on and so forth. So there is every possibility that HPV might enter the head and the neck, may result in head and neck cancer. Guess what kind? Squamous. Now, unbelievably, you will learn in immunology that you even have a vaccination for this, and it is called Gardasil. You are guarding against squamous intraepithelial lesion, where vulva, cervix, head and neck. Isn't that amazing that you actually have a vaccine that may prevent certain cancers from taking place? And then molecularly, if you remember from Michael with HPV, These strains contain E6 and E7. What do they do? Knock out the tumor suppressor gene P53, and what is the other one? RB, E6, E7 respectively. HPV, you should know everything about HPV. What about the lower strain? Condyloma acuminator. What? Remember what? That's your condyloma acuminator. Know everything about HPV, low strain, high strain. Our topic, high strain. Alright, let's move on to EBV. EBV is all over the place. Oh my goodness. Usually infects B cells. And if it is B cells, then what kind of CD are you looking for? Good, CD 19, 20, and 21. You should be focusing upon 21. These are epithelial cells of nasopharynx CD21. So if that's the case, is it possible that the EBV might give rise to nasopharyngeal cancer? Sure, who's your population? Far East, Japan and company. Our topic with EBV associated highly with Burkitt lymphoma, translocation 814 T814. By the time we are done with our discussion of cancer, we will have gone through three major translocations that contains 14. T814, T1418, T1114. Once again, T814 Burkitt, T1418 follicular, T1114, I'm sorry, what? Good. Mantle cells. Burkitt lymphoma, especially what if I give you an African American boy? The boss will give you an African American boy. Actually, not even Africa America. Literally from Africa, a child. Where is Burkitt lymphoma affecting that African child? Mandible. That is the one EBV is associated with more so we call that the endemic type. The non-endemic type, when we will come to that will be the North American type. Sporadic. Not so much with EBV, B-cell lymphoma in immunocompromised Hodgkin big time. The most common Hodgkin is not mixed cellularity. The most common Hodgkins would be the sclerosing type. Also associated with EBV, mixed cellularity as well. What do you have to find us pathologically on biopsy to diagnose Hodgkins? Without this, you cannot call it Hodgkins. Read Sternberg cells. What is it? It is a B cell that is a lymphoma and a nasopharyngeal. We began talking about the EBV and the CD21 population here, Far East. Our topic is DNA virus so far, HPV, EBV. Then you have hepatitis B. Why is there no hepatitis C here? Because hepatitis C is a RNA virus. So next, when we talk about RNA, we will talk about hepatitis C. Hepatitis B could be associated with chronicity, could be associated with hepatocellular carcinoma of the liver, RNA viruses that are important for you of developing cancer. Whenever you think about hepatitis C, you should be thinking about chronicity, hence associated with hepatocellular carcinoma. Then you have an interesting one here. It is called HLTV1, human T-cell lymphotropic virus 1. You focus upon the letter T. HTLV virus 1 may give rise to T-cell leukemia lymphoma. The gene here that you will have to know is TAX, THTLV1. Adult T-cell lymphoma, leukemia lymphoma, TAX. Know these three for your step. You will be in good shape. These are important RNA viruses. There are a bunch more, but at least know these two associated with cancer. Bacteria associated with cancer. Obviously, this brings us to H. pylori, Helicobacter pylori, Helicobacter pylori loves to live either in the atrium of the stomach, or it loves to live in the first part of the duodenum. So right around here, right in that area, the atrium and the first part of the duodenum, H. pylori. You talked about urease. You know that it produced a force field. This thing is like a superhero, but it's actually a supervillain, isn't it? It creates a force field composed of alkaline H. pylori, and at some point with H. pylori, it might give rise to a gastric adenocarcinoma. And that's called intestinal type. And Helicobacter pylori might then give rise to a second gastric cancer here, and it is called the MALT myeltoma, mucus associated lymphoid tissue. Welcome to a B cell type. Why am I emphasizing B? Because in the gut, in the GI system, if it is any type of lymphoma that the patient is going to develop, it's going to be a B cell. Extranodal non-Hodgkin's lymphoma, we call this a diffuse large B-cell lymphoma, can be reversed with treatment. That is unbelievable, isn't it? The fact that you can actually treat a cancer by giving H. pylori. Excuse me, you can treat a cancer by treating H. pylori. Antibiotics kills off the cancer. Of course, the boys will love this, and you are thinking about drugs such as H2 blocker. Maybe your clarithromycin antibiotic Bismuth is in there as well. And it is important that we pay attention to the management when the time is right. You also have a PPI as well.